Our next speaker is Dr. Dai and Professor Dai, graduated from the Kaohsiung Medical University for his MD, MS, and PhD. And now he is also a member of Taiwan Longitudinal Study on Aging, and also a cohort study on the daycare center network. So Dr. Dai has published many papers on the using the TLSA, Taiwan Longitudinal Study. Today, he's going to give us his summary on the from TLSA, that's the Taiwan Longitudinal Study on Aging, to comprehensive public health screening strategy in the elderly. Dr. Dai, please.
Thank you for the introduction of Professor Lee, and thank you for the invitation of the NHRI for this speech. And today I'm going to talk about the healthy influenza of the elderly and introduce the current public health screening strategy for the elderly in Taiwan. And then third, I will give a brief introduction of the TLSA study. And the final one, I will introduce our innovative approaches to how to use TLSA or other cross-sectional or longitudinal study to public health screening. There are myriads of healthy influences of the elderly, which include biological and psychological and genetic factors, including age and body indexes, including many biomarkers many speakers mentioned before. And the social factors, I believe the social determinants of health is the main factors which will influence the elderly and the longevity. And there is also the lifestyle and healthy behaviors and our healthcare delivery system matters. And the healthy outcome is successful aging, longevity, or we have discussed the dementia or depression, or the most important thing is the mortality, disability, and frailty. Here is the scheme of the screening strategy for the elderly in Taiwan, and we are now trying to integrate the ICOPE scheme into Taiwan since 2019. In Taiwan, we take the 8 major perspectives to do the first screening. However, we mostly use the questionnaires to do the first step of the screening. And the other screening tests include annual health exam, mostly based on the Framingham study. We examine the many factors including blood sugar, lipid profile for the evaluation of CV risk, and chronic kidney disease, and so on. And we also have the cancer screening. And in recent 2 years, we introduced the low-dose lung CT for the smokers and residents who has a strong family history. And for some local governments, and they will provide the extra examination, for example, the abdominal echo, or PSA, or some biological factors for the near poor or low income elderly. And also the Ministry of Health and Welfare and encourage the local health center to do the sarcopenia screening using the SCARF scale and or the SOF. And the last one, we only screen the social support or caregiver burden on the cares of the disabled patient. However, and I want to discuss, there are many screening strategy for the public health. The most common one is one shot for one target. It's like use only one, for example, the BMP for the heart failure. It's one shot for one target, or the one gene for the one disease. And the multiple arrows for one target is like use questionnaires. You use many questions and targeting at a priority. However, in my perspective, screening strategy for the elderly, especially to investigate the geriatric syndrome, is like the right side one. Maybe we have a one shot or the one screening test for multiple targets. For example, the hand grip may be highly associated with sarcopenia and maybe highly associated with frailty. And the other one is multiple arrows for multiple targets. It's like our comprehensive geriatrics assessments. So, can we find a better screening strategy from the experience of the population-based cohort study? So I want to introduce the Taiwan longitudinal study on aging first. There are a lot of longitudinal study worldwide, including TLSA and the J-STAR in Japan, and the NUJLSOA in Japan, and other study in Korea, China, and the UK, US. Also the science study in Singapore, And the TLSA establishment and follow-up now, the data has been opened for the 9th waves. It is from 1989 to 2019. It has 4 cohorts. You can see that the cohort initially included only patient age 60 and above. And as the time go by, the participants become younger and younger. And that's mainly because the Taiwan's government want to evaluate the early factors or early predictors and may try to intervene into the process of aging. The sample of TLSA, it is designed as a prospective cohort study, and the location is mostly the elderly and middle age in the non-Aboriginal townships. And both institutional and community dwelling participants are covered. And the strategy is stratified multi-stage probability sample. And so it is a national representative of age 50 and above. And the data collection is a face-to-face questionnaire interview, and the data linkage can linkage to the National Health Insurance database. And the variables in the TLSA include the many aspects, include the physical, psychological, and social determinants of health, which include the characteristics of patients and the healthcare service usage, and the pension or economic status, and the comorbidity. And physical function, we have self-rated health, mobility, ADL, IADL, and frailty scale. And social, psychological functions, in a TLSA, we use GDS-15 and SPM-SQ. And we also have the sensory impairment assessment, including the self-report hearing and visual impairments, and oral health impact profile, and so on. So after the introduction of the TLSA, I want to discuss what is our innovative approaches to public health screening, and I will give our example. The first one is the integration of questionnaire and function test, because most of the questionnaire will be influenced by the cognitive function. So in the public health screening, especially for the ICOP, I think we should integrate the questionnaire and functional test. And the second one, I want to echo the previous speaker. They say that most of the screening neglect the importance of social determinants of health. So I think we should collaborate with welfare and dental health system. And the third one, the third question is it possible we use the existing screening tool for the new target? And the fourth is we should pay more attention to the trajectory, not only to the instant or prompt test. And the first example is that, as I mentioned above, is the current screening strategy for the ICOP is we use questionnaires to evaluate the 8 domain of the geriatric syndrome. And we did an evaluation. We found that instead of asking a question, the physical function impairment and sarcopenia, gait, balance, and fall, these all can be tested by or screened by the dominant hand grip strength and then 6-meter walk test. And the second one is the hearing and visual impairment. Instead of using the questionnaire, we recommend using a ring test and a Snell scale test. And osteoporosis, we can use high loss or occiput distance or rib pelvis distance instead. And we have tested that our model is more efficient than just using the questionnaire. And the second example is for using or collaborate with the dental care system. And as we all know, we try to use the biomarkers or the questionnaire to predict the frailty or dementia. However, many older people has the dental problems. Therefore, if we can apply a screening tool in the dental clinic or integrate with the oral health practitioner, we may have a better screening rate. Therefore, we use the TLSA and use the stepwise logistic regression and selected that here's a composite of age and female and the oral health impact profile questions. But the question 3 is uncomfortable to eat, and the question 7 is test words. And in combination with the past history, like DM or CKD, it can has a integrated or composite model to predict frailty or dementia. So it can be applied in the dental system or the oral health practitioner to screen the frailty and dementia. And the sensitivity is quite good. The AUC is above 80%. And the cutoff for the frailty is 80, which means that if the age over 80, it is a high possibility of frailty. And each factor has the same weight of the age. But if you have diabetes or chronic kidney disease, the weight is doubled. So it is a quite different approach to the common screening strategy. And the third one is is an example for, is it possible to use the current screening tool for the new target? In this model, we use the annual health exam data and the social support or social pension data, and to predict whether a patient have sarcopenia. As you all know, the sarcopenia, the sensitivity of the scarf is around 40 or 50% only. And the predictor of this SARCF is about 60 to 70. So after we select this model, we can see that the composition of this factor, including age, female, do you receive the social assistance pension on the emphasis of exercise, is a healthy behavior, underweight, normal fasting, glucose level, and abnormal creatinine level. It can become a better screening tool in prediction of sarcopenia. You can see the AUC is about 75%. It is much better than the current using screening tool, the SCARF. And besides, it did not have to use another screening tool and take many manpower to do it. We can just screening from our national health database and to select the patient who has high risk of sarcopenia. And the last one is, I want to talk about the visual trajectory. And most of the question about the sensory impairment is the current state of the condition. For example, do you have the visual impairment right now? The question is mostly like that. But however, we found that instead of using the persistent visual impairment as a question, the visual trajectory from no visual impairment to visual impairment has a better risk, is a better predictor. Therefore, we think that instead of the question just asking about the instant or the current condition, we need to ask the trajectory or the changes of the status. It might be more beneficial as an indicator. And our many study has our domestic academic collaboration, include Taichung Hospital with Professor Lee and Zhongshan Medical University, NHRI, China Medical University, and so on. And our international collaboration also was University of Michigan, University of Minnesota Nihon University, and NCGG. And my take-home message is, do we have to use or find another biomarker for the screening of the elderly? And my answer is, maybe you can use current screening tool and one shot for multiple targets, or multiple arrow for multiple targets. So we may need a comprehensive or integrative screening system instead of using each screening test for one purpose. And it's quite important to integrate health and welfare system and dental health system. The last one is the population-based cohort. I think may shed new light on future screening strategy. So when we design a new cohort study or want to add a new biomarker to the cohort study, we have to find or think what kind of marker is promising. And thank you. This is my talk.